I'm pleased to be here live today with none other than Dr. Donn Posner, who's here to chat with us about insomnia. A brief introduction: Donn is a diplomate of behavioral sleep medicine, a founding member of the Society of Behavioral Sleep Medicine, and one of the first certified behavioral sleep medicine specialists recognized by the American Academy of Sleep Medicine. He's founder and president of Sleepwell Consultants, adjunct clinical associate professor at Stanford University School of Medicine, and consulting psychologist for the Palo Alto VA. Those are impressive credentials, Donn. Thank you so much for being here today.
Oh, thank you for having me, Victoria.
My pleasure. I'd love to hear your opinion about why clinicians should be asking their clients about sleep. This is not something that's always on clinicians' radars.
Yeah, I know. It should feel intuitive that sleep is so integral to everything that we understand about both physical health and behavioral health. That in some ways we should be asking the question, why wouldn't we be asking about sleep and insomnia? It impacts just about everything in our patients' lives. So we definitely should be asking about it. And unfortunately, the problem is that we don't. Part of the reason is, I think, as clinicians in any discipline, whether medical school or graduate school, we don't get a lot of training in sleep medicine. It's sort of left to the side. And therefore, we have data on the fact that very, very small percentages of clinicians, again, of all disciplines, do not ask even one simple question like, how's your sleep?
Mm-hmm. Mm-hmm. Yeah, there's some comments coming in already saying this is a foundational thing, and it sounds like you really would agree with that. And
Oh, yeah.
I don't know if you have insight into why more isn't taught on this in training programs. Do you have any sense of why that might be?
Well, I mean, it's like things competing for shelf space in a grocery store. The medical schools you got and graduate school, you've got a lot of things to teach, and it's always thought of as not enough room for this. I also think that in general, sleep medicine is a relatively new field in the history of medicine. So when I say relatively new, I mean 60 years, 70 years, when people really started thinking of sleep as something other than just 8 hours of unconsciousness to actually be studied and looked at. So that may be part of the reason, but also I think, especially from a mental health and behavioral health point of view, we have been taught that insomnia, especially, is something that is simply a symptom of all kinds of other problems. Therefore, why pay much attention to it when all you need to do is address the comorbid problem or the primary problem, and away will go the sleep problems? And the truth is, and I tell people this in the course, that what I hope to do in the course is deconstruct everybody's notion of everything that they learned about insomnia, deconstruct it down to the bare bones, and then rebuild it up. There's a wealth of data and information that tells us that everything we learned about chronic insomnia really turns out not to be the case, and it is holding us back and interfering with our ability to have the best impact for our patients.
So say more about this. So it's not the case that the insomnia will resolve once the PTSD is treated, once the depression is treated. Is that what you're saying?
Yeah, I'll say that and more. I think that it's not that again, can you have impact on sleep by treating those areas? You can, but not as much as you could if you directly target it. That what we see in the data is that one of the remaining residual symptoms that tends to be very tenacious and holds on with the treatment of depression and anxiety disorders and post-traumatic stress disorder is sleep, and the consequences of sleep, like fatigue, and so forth. And so it tends to hold on. And what is worse is what we've now learned is that when that insomnia is left alive and continues to be an ongoing, even sporadic problem, then it interferes with the fullness and richness of the treatment we can get for those other disorders.
Yeah.
So, for instance, we know that that the remission of depression in depression treatment is hampered by not treating sleep and not treating insomnia, and that when you treat that insomnia, you can actually double your remission rates in depression.
Wow.
Yeah.
Wow. So not treating it means clients still have lingering symptoms, and that those lingering symptoms kind of set them up for relapse, sounds like.
That is absolutely the way to think about it. And the
Yeah.
first symptom, if you look at the list of symptoms in recurrent depression, the first symptom to go is sleep.
Mm. Mhm. Mhm. Wow. That's really eye-opening. What can you say about um, the ordering of treatments then? If a client comes in with depression and they have prominent insomnia symptoms as part of that depression, are we treating depression first? Are we treating sleep first? How do we make those decisions?
So again, I think that it is precious few people who would think about ever treating sleep first. I will briefly, and I present this in the course, will say that there's now a wealth of studies that show that CBT-I, cognitive behavioral therapy for insomnia, is as effective in treating depression in people with comorbid depression and insomnia as cognitive behavioral therapy for depression.
Wow.
That cognitive behavioral therapy for insomnia is as effective in terms of effect size as antidepressant medication.
Wow.
So no one knows this, which is why I'm out there in the world trying to do these courses and
Yeah.
teach clinicians. So if you ask me personally, my feeling is the data tells us that a good leading way to start a therapy would be with CBT-I, because you might get to a point at least where everything else is now ameliorated in a way that makes it easier to work with,
Mm.
and you have no interference from the insomnia.
Mm.
And you may very well find, as I have found many times in my practice, that by the time you get to that talking about the depression, it's no longer evident. So
Wow.
you might not need to get there. And CBT-I is usually only 6 sessions, which is less than most of
Wow.
the depression treatments. All of that said, it's certainly going to vary from individual to individual client.
Right.
And at the very least, we should be thinking about doing concomitant treatments.
Okay.
That if you ask about sequencing, waiting and waiting and waiting on the insomnia, I think is a mistake. At least the two things at the same time, if not leading in. I'll say one more thing. There have been several studies in the VA with CBT-I and post-traumatic stress. And, veterans in the VA, they don't always want to go for mental health.
Mhm.
They see it as a little bit of head shrinking. It's a little too touchy-feely for them. And so they will decline going into that kind of therapy. When you say, would you be interested in seeing, say, the sleep specialist to work on your sleep and your insomnia problems, they will often sign up for that. The
Right.
work is very structured, very behavioral, almost like boot camp.
Right.
And by the end of it, they get really good outcomes. And what we find is a lot of them will then say, well, is this what therapy is like? And if this is what you mean by therapy, yeah, maybe I'll take a look at that prolonged exposure protocol that you said that you
Right.
had. So in the
Right.
VA, there have been people who have talked about CBT-I as a gateway therapy into others.
Yeah. Oh, I love that. And I imagine that that's true outside of the VA also. Working on sleep is much less threatening than delving into the sources of depression. And I think a
Sure.
lot of clients feel ashamed to be depressed, and they don't feel ashamed to not be sleeping well. So
Some, although
tap-
there are people who feel very funny about telling anybody that they can't sleep.
because they
Yeah.
feel like they should be able to sleep
Like
just fine.
everybody can do it. What's wrong with me?
I see. I see. Okay. And it sounds too, Don, like you're saying that if the treatment is so short term, clients, if they respond to CBT-I, are probably having that kind of reinforcing effect of, yes, therapy works, so I'll stick with it,
Mhm.
which sounds really important too, because there's a
Sure.
high, dropout risk for therapy.
Sure. Yeah.
The title of the training that you're doing with PESI is Beyond Sleep Hygiene. Sleep hygiene, I think, is the thing that we do get education on as clinicians.
Yeah.
Why are you talking about anything beyond sleep hygiene? Why do we need more than that?
Well, I mean, understand that sleep hygiene is a part of CBT-I, but it's never the starting point for CBT-I.
Okay.
Sleep hygiene, we now know, we've done the research, as a monotherapy. That is, if all you're doing is handing a patient a sleep hygiene list, like, decrease your caffeine consumption, decrease your alcohol consumption, get more exercise, quiet down your bedroom, darken your bedroom, those kinds of things. That if we do that alone for a chronic insomnia, that it doesn't work.
Okay. Mm-hmm.
That there's not much bang for the buck there. And probably a lot of the clinicians who might want to come to this presentation will already understand that, because they may have already gone over some of those things, and patients will, might say, oh, well, that was nice, but it didn't do much. In fact, I would say most of my patients, who by the time they get to me, they have some of the best sleep hygiene in the world, because they've heard this from everybody, including their clinician, their priest, their doctors, and everybody and their aunt and uncle.
Right.
And so they try to do it as well as they can, and it isn't enough. The best way to think about sleep hygiene is that it is a preventative set of strategies for maintaining good sleep. So think of sleep hygiene like we would think about dental hygiene. Sleep hygiene is like flossing and brushing, right? Is it good? Is it useful? Absolutely. Once you get a cavity or gum disease, will flossing and brushing fix that problem? And the answer is no. And that's the same way we ought to be thinking about chronic insomnia. Once the insomnia is chronic, which means more than 3 months, okay, then just flossing and brushing, if you will, isn't going to get it done.
Yeah. Yeah. That's such a great metaphor. And it's such good clarification, too. We're not just talking about like a one-off poor night of sleep. We're talking about a really insidious problem that some of our clients have. And we might not even know about it, too, unless we're asking specifically about it.
No, that's exactly correct. And especially for people who work in the crisis area, what I do like to say sometimes is that everything we learned about insomnia in graduate school is probably true for acute insomnia. That is, having a few nights in the week, having a couple of weeks, maybe even up to a month, where you're having some problems due to some immediate stressor.
Right.
And the notion that when we get rid of that stressor, or adapt to it, or treat it, or take a medication, that the insomnia will go away is often true. But in the chronic condition, that is not true. When we get rid of the stressor, it doesn't always go away. The interesting thing is, even learning CBT-I can help some of our clinicians, especially if they work in a crisis situation. They can learn some of the things of the tools in this therapy to help if they identify somebody who's just starting out having some bad weeks of sleep. They might be able to identify some things that can help them to prevent. Now we're talking about flossing and brushing to prevent that from turning into a more chronic problem.
Wonderful. Wonderful. So what would you say, Donn, are some key ways that clinicians can be assessing their clients for insomnia?
Well, I mean, because it's so poor in the field of medicine and behavioral medicine and behavioral health, I would say at least ask, right? Just a simple question of how's your sleep will get your patients talking to then say that they are or are not sleeping well. And then understanding a little bit about the definition of chronic insomnia. If you know what that is, you can then, if they say, yeah, I haven't been sleeping so great, you could get a little bit of a better sense of where they are in that trajectory, what kinds of things are happening. There are simple assessment devices out there. We'll talk about this in the course, but there's something that's used in a lot of the research and can be used clinically very simply, even filled out in the waiting room, that your patients can fill out, called the Insomnia Severity Index, or the ISI. And that is a form that simply will measure, the level of insomnia. So if somebody wanted to get a little bit more in detail, even without knowing a lot about sleep medicine, they might at least get a sense of how significant this problem is.
Yeah, I've seen that before. I believe that's the one that asks clients to get a little bit more detailed about what the problem is, right? Trouble falling asleep versus staying asleep, that type of thing.
And that's satisfaction during the day, but it's like a 7 item score. and then you just add it up and you've got a total.
Wonderful. Yeah, that's a great tool. Thank you for sharing that.
Sure.
Could you give us an example of one or two of the interventions that you're going to teach in your upcoming training?
Well, I mean, it's the core items. CBT-I is a multi-component therapy. So there are core items that are usually characteristic of anybody who's doing CBT-I. And the two ones that I think will wind up being the newest things that people learn within the course are sleep restriction therapy and stimulus control therapy. And then if you add to that, often in most cognitive behavioral therapies, there will be a section on sleep hygiene as a way of having people understand how, once they get better, how to maintain their gains. And then cognitive therapy, which is infused throughout the therapy, mostly to help people adhere to what it is they need to do with those behavioral therapies, but also as a way to challenge some of their sleep-related fears and so forth. So, cognitive therapy is something that a lot of clinicians already know how to do. They won't be relearning how to do cognitive therapy, but they will be learning particular ideas within the realm of education of sleep medicine that will help their patients to kind of hopefully let go of some of their anxiety. But sleep restriction and stimulus control are, in my book, where it's at. And those would be some of the main foci of what the study will talk about. People have probably heard some of these things. They've probably heard about stimulus control. Actually, one of my pet peeves, so stimulus control is just understanding that you should not be associating the bed with being awake and being fearful and being fretful and nervous and all of those sorts of things. So even the clinicians out there probably have some sense that, it's probably not a good thing to stay in bed. And we do ask our patients to get out of bed. I will tell you that one of my really big pet peeves is to have a line about stimulus control on a sleep habit list. Here are my sleep habits: decrease caffeine, decrease alcohol, yada, yada. And then I have a line that says, and if I'm not sleeping, get out of bed and then go back when I'm ready. Nobody has any understanding of, even the clinicians, of why we say that, why that should work, and the time frames. What we're basically talking about there in terms of theoretical underpinning is Pavlovian conditioning. And you can't get around that in one night. You're not going to unlearn what you've learned over years in one night. And yet that line on a sleep habit list never tells that story, never gives the person the understanding and the rationales for why they should be doing what they're doing. And so they do it for a night. It makes them worse rather than better. And then they never want to go near that again. So if I could impart one thing to the people who are watching now, is take that line off your sleep hygiene list. When stimulus control is done, it should be done right. And that takes a lot of explication.
And clients need to understand why too, otherwise they might not do it, right? We're asking them to get out of bed. It's counterintuitive to them. Bed is
and really hard
sleep.
to do when it's cold and all of that sort of stuff. So yeah, it takes, CBT-I takes a lot of, producing a lot of issues with regard to setting expectation and giving a ton of rationale.
Wonderful. Could you say just a little bit more about that second behavioral technique that you mentioned would probably be new to most folks?
Yeah, sleep restriction is a terrible name. It basically is saying that what we're going to do is limit the amount of time that somebody spends in bed, which sounds counterintuitive. And again, even in this time frame, for the folks that are listening, they may say, I don't want to learn this. That sounds stupid. It's counterintuitive until you understand something about sleep medicine, which has to do with normal regulation, the things that go into our normal sleep. And one of those things is sleep drive. We build a level of sleepiness over the course of the day. It's a homeostatic drive, not unlike hunger. And so the more we go from the time we wake, the more sleep drive we build. When people have chronic insomnia, they do a lot of things that weaken that sleep drive. And so what sleep restriction does is to say, look, when you're overly compensating for the poor sleep you have on one night, that can backfire and give you more nights of insomnia, which perpetuate the problem. So what we do is try to curtail and rein in when people are allowed to sleep and not sleep based on data from their own lives. that allow them to kind of build sleep drive in a very predictable way that lets us know that if they're adherent to the protocol, they're likely to start sleeping more solidly.
So we're yanking the naps, are we?
Well, yeah, yes, the first thing anybody would think of is you're going to yank the naps. And that actually doesn't always have to be the case. It depends on the patient.
Right.
But even more so, things like, going to bed early and sleeping in late and crashing on weekends will have even more impact on sleep drive than even the naps.
Yeah. We have so much to learn from you, Donn. Thank you so much for sharing these nuggets today. This is a fascinating and important topic that doesn't get near enough attention, it sounds like. Everybody, you have an opportunity to learn more from Donn on February 3rd at the upcoming webinar. There's information on it at the bottom of your screen here. Donn, again, thank you so much for joining us today. This was so wonderful to learn about from you.
Thanks, Victoria. This was great. Thanks for having me. Hope to see you all there.